ECG in patients with implanted pacemakers are difficult to interpret as QRS, ST and T-wave morphologies change in ventricular pacing. P-wave morphology changes if there is atrial or dual chamber pacing. ECG changes will depend on whether it is continuous or intermittent pacing. In some cases, paced rhythm may not be visible even though the patient has an implanted pacemaker. This happens when the indication for pacing was an intermittent condition, so that pacemaker gets inhibited when the spontaneous rhythm dominates. Digital processing of ECG signals may also mask the pacing artifacts, making their recognition difficult. This can be tided over by changing the filter setting so that low-pass filter is set at 150 Hz. Basic rhythm in this ECG is a paced rhythm with pacing spikes or pacemaker artifacts seen immediately before each QRS complex. The QRS complexes have a left bundle branch block pattern with a superior axis indicating right ventricular apical pacing. An ectopic beat with right bundle branch block left anterior hemiblock morphology has occurred in between, causing the pacemaker to be inhibited transiently, indicating that it is a demand pacemaker working in VVI mode. In VVI mode, the chamber paced and sensed is the ventricle, and the response to a sense beat is inhibition of pacing. After the regular pacing cycle, the next spike occurs, but the QRS complex has a morphology intermediate between the spontaneous beat and the paced beat, with a slightly narrower QRS than the paced beat. This is a fusion beat between a paced beat and a spontaneous ectopic beat which has occurred just after the onset of the pacing spike. The ectopic beat could either have a left ventricular origin due to RBBB morphology or a supraventricular origin with aberrant conduction. This ECG shows a paced rhythm at around 60 per minute with pacing spikes preceding each QRS complex. At first look, it may seem that there is a P wave before each QRS with a reasonable PR interval suggesting atrial sensed ventricular pacing. But close scrutiny shows that PR interval is gradually varying. The atrial rate is also close to 60 per minute, making false appearance of an AV synchronous pacing in some beats. The QRS pattern mimics LBBB pattern with left axis deviation, as is usual with right ventricular pacing. If the lead tip slips and paces the right ventricular outflow region, it will give an LBBB pattern with inferior axis. Right bundle branch block RBBB pattern, if it occurs in the setting of temporary pacing, may indicate lead tip perforating either the interventricular septum and pacing the left ventricle endocardially, or the right ventricular free wall and pacing the left ventricular epicardium through the pericardial cavity. ECG showing atrial and ventricular pacing spikes, also known as pacing artifacts. Atrial pacing spikes precede the ventricular pacing spike by the programmed AV interval. In this ECG, though the atrial pacing spikes are seen, atrial capture in the form of paced P waves are not visible. It is possible that there is atrial non-capture either due to high thresholds or an atrial lead displacement. Another possibility is that the paced P waves are isoelectric in the recorded leads. Regular ventricular capture is seen after each ventricular spike. The paced QRS complexes are wide and having left bundle branch block pattern with left axis deviation, suggesting a ventricular pacing site at right ventricular apex. Initial part of the ECG shows narrow QRS complexes at a rate of around 43 per minute. Dissociated P waves can be seen at a rate of around 75 per minute. T wave inversion is noted in lead 1. After the initial two complexes, the ECG shows a wide QRS rhythm at around 70 per minute with a spike seen just before the QRS complexes. In some leads, the spacing spikes are quite small or even not visible. Pacing spike is well seen in most of the chest leads. Dissociated P waves are seen in the paced rhythm as well, as it is a ventricular pacing and not AV sequential pacing. Some of the P waves fall on the T wave and manifest as notching of the T waves, but can be identified by their timing. In one case, the P wave is at the apex of the T wave and makes the T wave peaked. Paced beats have a left bundle branch block pattern with negative QRS complexes in inferior leads, indicating pacing from the right ventricular apex. This pattern is seen as wide S or QS complexes in anterior leads and slurred R waves in lateral leads. T wave inversion in lateral leads in the paced beats is secondary T wave change due to primary abnormality of depolarization sequence, with right ventricle being activated first and left ventricle activated slowly by spread of impulse through the myocardium. QRS complexes are negative in inferior leads as the activation starts from the apical region and spreads upwards away from the inferior leads. At a glance, this will seem to be a simple LBBB, but the QRS complexes are negative in V5 and V6, unlike in usual LBBB. It is actually AV sequential pacing. A close scrutiny will reveal the small pacing spikes just before the QRS complexes, markers in V3 and V4. They are small because pacing spikes have high frequency components and get filtered off by the low pass filter of the digital ECG machine. Hence, pacing spikes, especially the small pacing spikes of bipolar pacing, are ironed out by digital ECG filters. If the low pass filters are removed and an upper frequency limit set at 100 Hz or more, the pacing spikes can be seen well. In case of modern digital cardiac monitors, there is an option to detect pacing spikes, which, if enabled, will enhance the pacing spikes very much so that they are easily visible. In this ECG, each P wave is followed by a PR interval terminating in a pacing spike and QRS complex. This shows that the pacemaker ventricular pacing is tracking the P waves. This requires either an atrial lead as in dual chamber pacing or an atrial sensing electrode as in case of a single lead VDD pacemaker, that is ventricular paced, dual chamber sensed, having dual response, inhibited for ventricular sensed beat and triggered for atrial sensed beat. The discordance between the QRS patterns in leads 1 and AVL versus V5 V6 should make one suspect a pacemaker rhythm and not a simple LBBB pattern. In simple LBBB pattern, there is concordance between the lateral limb leads and chest leads. This ECG shows a wide QRS rhythm with LBBB pattern in 1 AVL and V1. Axis is leftward and V6 shows negative QRS complexes, indicating pacing from the right ventricular apex. Pacemaker artifacts of spikes can be seen on close scrutiny in V4 to V6 just before the onset of the wide QRS complex. Andrograde P waves are seen dissociated from the QRS complexes. Hence, the basic rhythm was complete heart block, which needed a pacemaker. Retrograde P waves, marked as P prime, are seen after the paced QRS complexes in lead 2 ECG rhythm strip, with a reasonable retrograde conduction time. This is an interesting situation in that andrograde complete heart block coexists in the presence of fairly intact retrograde ventriculoatrial conduction. 12-lead ECG showing paced rhythm with a very wide QRS and atrial fibrillation. ECG shows a paced rhythm with a wide QRS of 200 millisecond width. A prominent pacing spike is seen before each QRS complex, indicating a ventricular paced rhythm with complete capture. Coarse atrial fibrillary waves are seen in leads V1 and V2. Hence, the underlying rhythm at present is atrial fibrillation. The fact that the pacemaker has been implanted would suggest that there was an indication for pacing earlier. This person had left ventricular dysfunction and consequent atrial dilatation, accounting for coarse atrial fibrillary waves. The enhanced width of the QRS indicates higher amount of myocardial damage, which has led to ventricular dysfunction and a more disorganized intraventricular conduction. The wide QRS with left bundle branch block pattern in right ventricular pacing could worsen the left ventricular dysfunction by intraventricular dyssynchrony between the contractions of the interventricular septum and left ventricular lateral wall. This is one of the downsides of right ventricular apical pacing. The apical location of the pacing site is evident from the negative QRS complexes in inferior leads, that is superior axis. This disadvantage of RV apical pacing in terms of dyssynchrony and progressive worsening of LV function have prompted investigators to look at options like RV outflow septal pacing, direct His bundle pacing, and even biventricular pacing in order to prevent this vicious cycle. Various pacing algorithms to minimize ventricular pacing in cases of sick sinus syndrome are also in use while pacing from the right ventricular apex in those who are not pacemaker dependent. Another possibility to be considered when AF is seen in a paced ECG is the implantation of a pacemaker after ablation of the AV node. This is done in refractory AF in which rate control with drugs have either failed or has produced intolerable side effects. Intermittent pacing in complete heart block could occur if the complete heart block is intermittent. Pacemaker functions only when the heart rate goes below the minimum set rate. It could also pace intermittently because of defects in the pulse generator or lead related problems like high threshold, lead displacement, insulation failure, or break in the conductor of the lead. ECG showing complete heart block with wide QRS escape rhythm and a few paced complexes with pacing artifact immediately preceding the QRS complexes. Independent P waves are also seen. In this case, the intermittent pacing was due to battery failure of the pulse generator and a pulse generator replacement was needed. Biventricular pacing is used to reduce ventricular dyssynchrony in left bundle branch block with left ventricular dysfunction and refractory cardiac failure. Right ventricle and left ventricular lateral wall are paced to reduce the QRS duration and enhance synchrony of left ventricular contraction. Left ventricular lead is placed in a posterolateral vein after passing through the coronary sinus. In addition, AV sequential pacing is achieved by placing a third lead in the right atrial appendage. When only biventricular pacing is done, it is called cardiac resynchronization therapy, CRT or CRTP. If a defibrillator is added, it is called CRTD. ECG showing wide QRS complex with duration around 160 milliseconds, left atrial overload and left bundle branch block pattern in V1. This ECG was taken prior to implantation of the device. ECG after biventricular pacing showing the decrease in QRS width due to resynchronization. Pacing spikes are not visible due to the low setting of low pass filter, which tends to remove the pacing artifacts which are of high frequency.